Ladies and gentlemen, welcome back to Chapter 6 of MedQuest Gastroenterology for the ABIM. We're now going to be talking about upper GI bleeding and end-stage liver disease. Let's start with our first case. A 74-year-old male presents with hematemesis and 3 watery black bowel movements over one day. There's been 2 weeks of increasing fatigue and jaundice. He takes naproxen for headaches. He has an elevated temperature, blood pressure is low, he's tachycardic. His sclera are yellow. He has decreased bowel sounds, tense ascites, and trace lower extremity edema. Lab results are as follows. His white count's elevated at 14,000, AST is 145, his albumin is low at 2.2, his hematocrit's 28, his ALT 66, his PT, which is about 22, INR of 3 is obviously elevated, his platelets are low at 77,000, his bilirubin's markedly high at 12.7, his alk phos is about 144. We're building the classic liver patient here, aren't we? The question they want to know is which of the following is true. And they're going to give you all of these choices. And they're going to say, well, number 1, octreotide should not be given until an endoscopy is performed. True hematocrit's likely around 20 and 2 units of blood should be given. That's the correct answer. FFP should only be given if the bleeding continues. Antibiotics should not be given prophylactically. Now let's talk about these choices. Number 1, in a patient with liver disease is coming in with hematemesis, the most likely diagnosis is going to be varices, so you must give octreotide. You start it even before the endoscopy is performed. FFP is always given because these patients have coagulopathy. Antibiotics should also be given prophylactically because blood in the gut will cause transmigration of bacteria, and if a patient already has ascites, that E. coli is going to cross the small bowel and be like, look at this amazing place to live. Bam! He's going to go ahead and give you small spontaneous bacterial peritonitis, because for him, ascitic fluid is nothing better than what? A bacterial frap. That's right. For him, it's a frappuccino. He's going to love it. He's just going to multiply and multiply like good old bunny rabbits. Now, after stabilization, a paracentesis reveals a white count of about 200 WBCs, and 80% of them are PMNs, and an albumin of 0.5. What does this actually indicate? What this indicates is that portal hypertension is present. A lot of you thought, well, 80% of 200, oh my God, he must have SBP, because they're talking about a PMNs, but you have to have greater than 250, and therefore, portal hypertension is present, but not SBP. Now, in our next case, the upper endoscopy in this patient finally reveals that there are varices which are treated by band ligation. A clean base ulcer is identified. And what should you do in this case? Well, what you're going to do is the answer A. The risk of rebleeding from a clean base ulcer is low. They don't talk about anything here to do with banding. However, if you saw varices, you would go ahead and band them. But the only choice here that's true is choice A. Clean base ulcers only rebleed less than 5% of the time. Now, they mention in C band ligation. Sclerotherapy is not superior and is actually associated with worse outcomes in the patients. Now, the same patient 3 days after admission continues to have fever and jaundice. What medication should be started? The answer here is going to be prednisone. That means that this patient's good old discriminant factor is too high and you got to start prednisone to decrease mortality. Your next case is a 45-year-old woman with end-stage liver disease who presents to your office after being hospitalized for bleeding varices. He was discharged 1 month ago. After band ligation was performed, pantoprazole was prescribed. His last endoscopy was at the hospital at the time of the last band ligation. He feels well with no further episodes of rebleeding. There's obvious ascites and lower extremity edema. Sounds familiar, doesn't it? Which of the following would you recommend to this patient? Propranolol, spironolactone, furosemide, band ligation, or all of the above? For those of you who are thinking, well, they all sound correct, it's because you're right. They all do. You have to be on a non-specific beta blocker to prophylax against future variceal bleeds. You also want to be on spironolactone and furosemide to help decrease the acidic burden. And you must do upper endoscopy to go ahead and band ligate all of those varices. A 35-year-old accountant, otherwise healthy, after having 2 episodes of melena, comes to the emergency department with tachycardia. He's given 2 liters of saline. And upper endoscopy shows a clean-based 1 centimeter ulcer in the antrum. Hematocrit is 35. After hydration, vitals are normal. Rectal exam reveals dark brown stool. That's occult positive. And they want to know, how are you going to basically dispo this patient, the disposition of this patient? Now remember, ladies and gentlemen, disposition means more than just full code, DNR. If you ever write either one of those about disposition, you're doing something incorrect. Disposition means what is the outcome of this patient's admission. And now, with a patient who has a clean-based ulcer, who's hemodynamically stable, you can actually discharge the patient safely, follow up as an outpatient, prescribe omeprazole for a period of time, avoid aspirin and all non-steroidals. Ladies and gentlemen, I'm Dr. Mohammed. That's upper GI bleeding and end-stage liver disease. I'll see you in the next chapter when we discuss that beautiful organ, my favorite organ in the whole world, the pancreas. Oh yeah.